Hello, and welcome to the P2 Network PEM POCUS lecture series. My name is Matthew Moake, Assistant Professor of Pediatric Emergency Medicine and Director of Pediatric Emergency Ultrasound at the Medical University of South Carolina, and today we're going to talk about the posterior tibial nerve block. Our goals and objectives for today's lecture are to review the indications, contraindications, and complications when performing blocks, discuss the probe, supplies, and setups needed, talk about nerve identification and normal anatomy, review the procedure, discuss pearls and pitfalls, and review a few illustrative cases. The posterior tibial nerve is the terminal branch of the sciatic nerve and provides sensory innervation to the majority of the plantar foot as shown on the image to the right. Indications for performing the posterior tibial nerve block include painful procedures involving the sole of the foot. These can include lacerations, foreign body removal, incision and drainage, burns, fractures, and dislocations. One caveat to fractures and dislocations is to keep in mind that the bony osteotomes of the foot typically involve two nerves for innervation, and so in addition to the posterior tibial nerve, to get full anesthesia for a fracture or dislocation, you're likely going to need to block the deep peroneal nerve as well. Contraindications to performing this or any other block include allergy to anesthetic or gel, anticoagulation, pre-existing nerve injury or neuropathy, having a non-responsive or nonverbal patient who cannot communicate signs of nerve injury, infection at or near the injection site, or hardware at or near the injection site. Complications associated with performing this block are exceedingly rare. They include the usual procedural complications of bleeding, infection, and local injury. Nerve injury is even more rare at less than 0.04%, and when this occurs, it's usually self-limited and self-resolving. Most severe, but also luckily incredibly rare at less than 0.02%, is local anesthetic systemic toxicity, or LAST. LAST can present with a myriad of symptoms that can be very nonspecific, all the way to very severe, involving the cardiovascular and central nervous system. Keys for any provider performing regional anesthesia are to be able to recognize the symptoms of LAST. If suspected, you need to stop your anesthetic injection, provide supportive care, and in more severe cases, treat with intralipid. With this being the treatment for your most severe complication, it is recommended that anytime you're performing regional anesthesia that you have intralipid immediately available in your unit, whether that be in your med pyxis or right at the bedside. When performing your posterior tibial nerve block, you want to make use of the linear transducer. The high frequency with the linear optimizes your nerve visualization. You typically want to use a nerve or MSK settings. Your depth should be adjusted such that your nerve of interest is sitting approximately midfield, and it is our practice to make use of a probe cover when performing regional anesthesia. Supplies needed when performing the block are your sterile supplies. In this case, we have sterile gloves, your sterile probe cover, and sterile gel. Something to clean the skin. In this case, we've got a ChlorPrep. You're going to have to choose one of two needle options. We typically use for our extremity blocks a hypodermic cutting needle. In this case, we've got a 27 gauge needle to be attached to a control syringe. We've also got an 18 gauge needle to drop our anesthetic. You can also make use of an echogenic block needle shown here with a secondary syringe to have your anesthetic in it. Keep in mind that if you use the block needle, you need two providers. One provider will be holding the block needle as well as the ultrasound probe, while the second provider will be holding the syringe with your anesthetic and doing your actual injection. Along with these supplies, you need your anesthetic. You can use either a short-acting anesthetic such as lidocaine or a longer-acting anesthetic such as ropivacaine or bupivacaine. That all depends on how long you want your block to last. We typically use lidocaine just to get us through the procedure itself. One recommendation is to have all these supplies pre-gathered in little block kits shown here. This saves other members of your department time and having to collect supplies for a block, and I find it increases the performance of blocks. Setup for the block is shown here in the image on the right. You typically want to have your patient either decubitus or prone positioning. My personal preference is decubitus positioning. That provides a nice access to the medial lower leg as shown here. It's good practice to have your patients on monitors anytime you're doing a block. When you're doing a smaller single nerve peripheral block, it's reasonable to be off monitors. You definitely want to have patients on monitors if you're doing a larger field block, as this is a higher prone risk for LAST and other complications. That being said, it is our practice to have patients on monitors even for single blocks. You want to make sure you've got a nice procedural line of sight. Here we have one of our faculty and fellows performing a PT block on me. You can see I'm in decubitus position here. There's nice access to my medial lower leg, and the fellow who's blocking me has a clean line of sight from her eyes to the probe to the screen there. Also important is having good hand support. That implies hand support both for the probe hand as well as the hand that's going to be manipulating the needle. Next up, we're going to discuss nerve identification. You want to start with your probe oriented in the transverse axis, typically at the medial ankle at the level of medial malleolus. At this level, it's very easy to see the posterior tibial nerve with this associated neurovascular bundle shown here. We've got our nerve and a couple of the vessels in the PT neurovascular bundle. The PT nerve, just like other peripheral nerves, has a classic honeycomb structure that's easily seen here. That honeycomb structure is composed of individual fascicles of hypoechoic nervous tissue with surrounding hyperechoic connective tissue, artistically rendered here in this image. Once you identify your nerve, you want to track it proximally, ideally above the Achilles tendon. That provides two benefits. One, it ensures you a nice, clean, perpendicular line of needle approach. It also helps to ensure that you capture the calcaneal branch of the PT nerve, which anatomic studies have shown can come off anywhere as high as 10 centimeters above the base of the foot, so you don't want to miss that. Another important concept when discussing nerve identification is the concept of anisotropy. Here we're looking at the median nerve in the forearm. Initially, we have a nice perpendicular angle of incination with our probe, highlighting that median nerve really well. You'll see as we fan the probe back and forth, however, we go from that nice crisp view of the nerve when we're nice and vertical, and when we have a more oblique angle with the probe, we have a far inferior view of the nerve, and that's owing to the fact that when we are vertical, our sound waves are coming down, hitting the nerve and bouncing right back to it. But when our probe angle is hitting it in a more oblique angle, the waves come in, they're refracted off, and we lose a lot of signal coming back. So really, not only when you're tracking, you want to find that location of the nerve with the movement of the probe, you also want to spend time fanning to make sure you've got that optimal angle of incination. Next up, we're going to discuss the normal anatomy. Here we have the normal anatomy shown at the distal ankle. We're in a transverse approach, probe marker oriented posteriorly towards the patient's Achilles. On the right, you can see the ultrasound view of the anatomy that is highlighted here. We have our hyperechoic cortex of the tibia on screen bottom right. You've got three different muscles of relevance here. You've got your tibialis posterior, your flexor digitorum longus, and your flexor hallucis longus, and located between those last two muscles is your posterior tibial neurovascular bundle here, with the typical orientation of one artery with a couple flanking veins and your nerve shown here. Removing those labels, you can see again artery, two veins, and the nerve tucked in between those muscles. Next, we'll examine the normal anatomy, having advanced our probe proximally above the level of the Achilles. Again, we're in a transverse orientation with our probe marked posterior. The normal anatomy is seen on the right. Labeled here, we can see the similar two muscles, the flexor digitorum longus and flexor hallucis longus, with our neurovascular bundle sitting between those two muscles. This time now we have the soleus muscle coming into view, having advanced again above the Achilles. Also to take note of here is we have this potential space, this fascial plane sitting between these muscle layers. It's within this fascial layer that the posterior tibial neurovascular bundle sits, and our ultimate goal will be to insert our needle just within that layer to allow our anesthetic to spread up and around and bathe within the nerve. Removing these labels, you can see the anatomy again here. Here, we'll be able to watch the tracking of the nerve as we go from distal, moving proximally with our probe. Again, transverse orientation, probe marker oriented posterior. Here we have our nerve and neurovascular bundle sitting at the mediomalleolar level. As we advance the probe proximally, you can track that nerve moving upwards. You'll see the bony landmarks begin to fall away and more muscle of the soleus coming in from screen left until we get to the level here, where we're now sitting just above the Achilles tendon with that nerve sitting nicely within a bed of muscle. You can easily imagine bringing your needle in with a nice perpendicular line to come in just beneath that nerve. Now, having found our nerve and tracked it up to the level we want to do our injection, we'll go ahead and proceed with our procedure. First, you have to choose your injection approach. There are two different injection approaches you can use for nerve blocks. Similar to what you can do with a vascular access, there's an in-plane approach and out-of-plane approach. It's our practice to do virtually all of our nerve blocks with an in-plane approach. This provides superior needle visualization, really lets you guide that needle to the inferior component below the nerve. You certainly can do an out-of-plane approach, in particular for the PT block. If you're doing the block at the level of the medial malleolus, the out-of-plane approach may be ideal. As you can imagine from the image on the right, with this orientation, you have very little room to bring your needle in from the posterior anterior approaches, but you may be able to come in with an out-of-plane approach, similar if you wanted to cannulate a vessel in that area. Once you've chosen your approach, you need to guide your needle to the nerve. Your target should be to guide the needle just inferior to the nerve. This accomplishes two things. First, it helps to prevent any inadvertent air that may be injected to be shrouding the view of structures below. Second, as you inject your anesthetic, it tends to cause the nerve to lift a little bit, which makes it easier to see. You want to avoid direct contact with your nerve, and you absolutely do not want to inject your anesthetic within the nerve itself. Once you've guided your needle in, you want to aspirate to ensure that you are not intravascular. Certainly with ultrasound, you should be able to visualize your needle tip and where it is sitting within the tissue to know that you're not in a vessel, but it's still always good practice to aspirate before injecting. Once you've done that, you want to go and inject your anesthetic and observe its spread. We'll typically inject about 5 cc's per nerve. You do not need circumferential spread of your anesthetic when doing this injection. As long as you've got a nice collection of anesthetic next to the nerve, you should get a nice dense block. Here we'll watch that procedure through its steps. Once again, we're just above the level of the Achilles, transverse orientation, probe marker posterior. We can see our nerve and artery sitting here about mid-depth on the right side of the screen. We can also make out that tissue plane with that potential space. That's going to be our target for where we want to bring that anesthetic in. Our goal is going to bring our needle in from the screen left, from the posterior side of the leg, just past that tissue plane underneath the nerve, and we'll deposit our anesthetic and watch it spread around the nerve. Here you can watch the needle coming in from screen left. You can get a nice view of the bevel of that needle and the reverberation artifact coming off of the shaft of the needle. We got our needle just through. You can actually see briefly, it sort of separates that potential space. You start to inject and you can intermittently see that needle sort of backing in and out of that ideal spot. You've got your anesthetic spreading in here. Once again, you'll see a nice clean pool of anesthetic sitting next to your nerve. And when they back out just here, that spread goes up and around the nerve, which is your optimal spot for that infusion. Some pearls and pitfalls when performing this procedure. Remember to try to inject above the level of the Achilles tendon. This allows a more perpendicular needle path and ensures capture of the calcaneal branch of the PT nerve. Support both your probe hand and injecting hand to optimize needle control and visualization. If you don't see the needle tip, don't advance. This is the way you guarantee that you're not going to have inadvertent injury, inadvertent intravascular infusion, or some other complication. Aim your needle to the inferior side of the nerve. This lifts the nerve and avoids inadvertent air injection shrouding your view. Look for that tissue plane to unzip. When you're in that perfect fascial plane, you'll see that anesthetic cleanly collecting and sort of driving up and around the nerve. Choose your patients wisely. Utilize anxiolytics, Freezy spray, and Child Life to optimize tolerance in younger children. Next, we'll discuss a couple illustrative cases. Our first case is a 15-year-old female with an abscess surrounding a plantar wart, as shown on the left here. You can see your abscess, as well as some spreading erythema extending up around the arch of her foot. We discussed with the family pain control and consented for a posterior tibial block. Here you can see a view of the block in process. We're just above the level of the Achilles and transverse axis. Her anatomy is shown here with the nerve artery here, and the needle is actually already located just posterior to the nerve. You can see our needle tip moving just here, starting to slowly inject anesthetic. You can see that hypoechoic spread of the anesthetic starting to form. Here we hit that fascial plane. You can see the anesthetic starting to extend up and above the nerve. Got that nice collection of hypoechoic anesthetic sitting here bathing the nerve. She had a nice dense block. We were subsequently able to do an incision and drainage, and with the course of breaking up the abscess loculations, we're actually able to remove a good chunk of the core of that wart. Our second case is a 7-year-old autistic male who came in with concerns for a plantar foot foreign body. Here he had an x-ray as well as an ultrasound done, both of which demonstrated a linear, radiodense, and hyperechoic and ultrasound foreign body consistent with a sewing needle sitting in the plantar surface of the foot. We discussed management options with the family, and after giving him some PO midazolam and with use of Child Life, we were able to successfully perform a PT block. Here's a view of his PT nerve and artery sitting just above the level of his Achilles tendon. Goal will be to have that needle come in from the posterior leg, advance just posterior to the nerve. You can see the needle coming in here from screen left. You'll note here have a little bit of loss of that needle tip, which is suboptimal. Get a surrogate where that needle is with the tissue movement, but your ideal would be to see that needle tip perfectly. You can see the tissue moving just next to the nerve, so we go ahead and attempt a little bit of anesthetic injection to find the needle. And you'll see here the anesthetic starts to spread in just right at the base of the nerve where we want it to be. And you can see you're going to have nice dense anesthesia with that anesthetic sitting there starting to bathe up and slowly starting to extend itself around the nerve. Once we had our block in place, we were able to successfully remove that foreign body. The block actually worked so well that we were mid-procedure, and mom came around to the end of the bed to ask us if we had started yet, and we had a hemostat fully buried in the patient's foot, and he had no idea that we were even proceeding with the procedure. In summary, a few key take-home points. The posterior tibial nerve block provides analgesia for the majority of the plantar surface of the foot. The nerve is easiest identified at the level of the medial malleolus and then tracked more proximally to optimize needle trajectory. Set up for success, support your hands, and always know where your needle tip is. And lastly, be aware of the indications, contraindications, and complications of regional anesthesia when performing this or any other peripheral nerve block. Thank you. I hope you enjoyed this lecture, and feel free to reach out to me with any questions.